I'm going to hand over to Pete first. So Pete Gordon's head of emergency care improvement, and has been, a name linked to Red and Green Days and the Safe Patient Flow bundle for many years. And Peter's got a few slides he wants to share just in terms of setting the scene and opening it up to discussion. So I'm going to hand over to Pete.
Yeah, thanks, Nick. So hello, everybody, and welcome to the session. So my name is Pete Gordon, Head of Emergency Care Improvement with ESIST, which stands for the Emergency Care Improvement Support Team. So I'm joined by my colleagues, Nick, who's just talked, who's an improvement manager, Steve Barden, who's a doctor and acute physician extraordinaire from Brighton, Helen, who's one of our senior improvement managers, and Spencer, who's one of our improvement managers. So the session was labelled as red to green. So we're going to start it with that. I'm going to do a few slides just to get the ball rolling, and then we're going to have a conversation in true ESIST style, very pragmatic. It's a conversation, no questions, a silly one. So the title of the session was red to green, which stands for Red and Green Days. What I would say is, though, is just taking it back to the start of Red and Green Days, because the approach has been what we would say probably slightly weaponized, with maybe people who are into performance managers taking sort of the approach over. But the origination comes from a couple of consultants who used to work for ESIST. And it's no more complicated than this, really. It's a red day for a patient, for a person who's in hospital. There's a day when not everything happens that should. So, for example, if I'm due to have a diagnostic test and it doesn't happen and the results aren't written up and it isn't communicated with me, that would be a red day. If I can get out of bed and get moving, that's a red day. If I'm a patient and I don't have a clear plan that I'm aware of, that's a red day. If I should have a senior review today and it doesn't happen, that's a red day. And one of our top tips about red and green days is to keep it as simple as possible. And this is the journey of a lady in her 80s called Betty. And when we mapped her number of green days compared to red days, she had a 66-day stay in hospital. You can see there's an awful lot of red days. And it's one approach, and the trick is, I guess, to keep it as simple as possible. We're going to sort of expand the conversation out a bit beyond red and green days. I'm just going to talk about some of the evidence, because one of the things we are really keen to talk about is waiting. When I'm talking about waiting, I'm talking about waiting from a person's perspective, from a patient's perspective, and the effects of unnecessary waiting. So this is a study, fairly recent study, which talks about the association between delays to patient admission from emergency departments and linking it to all-cause 30-day mortality. The conclusion from this study, really big study, for every 82 admitted patients whose time in inpatient bed transfer is delayed between 6 to 8 hours from the time of arrival at the emergency department, there's one extra death. So I guess, when you look at the research, is the key point is waiting isn't passive, it's positively dangerous. And some of you may have heard of someone called Professor Brian Dolan, who's a good friend of many of ours, and ESIST, well, he seems to be the friend of everybody, actually, but he coined the phrase the last 1,000 days when he was working in Canterbury, New Zealand, with a group of geriatricians and nurses and AHPs. And, he had this phrase: if you had 1,000 days left to live, how many of those would you choose to spend in hospital? And I often think about my 91-year-old father, who probably is in his last 1,000 days, although he'd hate to admit it. And I think that sort of captures, as well as, you look at the research, it captures the minds, and, you think, wow, but also captures the heart as well. And also the fact that 48% of people over the age of 85 die within 1 year of hospital admission. So time's important. And what we do know is lowering levels of bed occupancy. So this is a study from a big teaching hospital in the Midlands. And what it showed was, by reducing bed occupancy, there's a mean reduction in all markers of mortality across the board. And sometimes we mix up performance management, and we don't, we sort of concentrate, hit the target, miss the point. But the point is, it's around safety, it's around saving lives. But I guess the other point, and for those of you listening who are out there, is we know that a lot of the solutions are there, and the good ideas, they're always with the people doing the work. And how often, remember when I was in nursing roles and ops roles, I'd go to someone with, you know, something which was vaguely innovative, and I'd get this response, your proposal is innovative. Unfortunately, we won't be able to use it because we've never tried something like this before. And I don't know about you, but me, I can be a bit mischievous at times trying to do things, but you know, this probably isn't the right response. But our experience, ESIS is a pragmatic on-site improvement team that goes all over the place. The places that do really well are the places that listen to their frontline teams. So before I finish, just a few things. When I think about red and green days, I think about the person in the bed, hopefully not in the bed, the person who's up from the bed and up and moving, because we know that has huge benefits. But these 4 questions, which originate from one of our previous doctors, Dr. Ian Sturgis, and he felt that these are the 4 questions that every patient and their loved ones should be able to answer. And there's nothing controversial here. Do I know what is wrong with me, or what has been excluded? Do I know what is going to happen now, later today and tomorrow to get me sorted? What do I need to achieve to get home? The saying, oh, you need to be back to baseline, is rarely a useful phrase. What are the things I need to do? And if my recovery is ideal and there's no unnecessary waiting, when can I expect to go home? And you might call that the expected date of discharge. So to me, you know, I think if my mum and dad, or my son who has special needs, one of my sons, they're in a hospital bed, and they or me, I can't answer these questions, I think that's a red day. And we've put these past probably thousands of people, including patient and care organisation, and no one disagrees with them. Yet, an awful lot of complaints come across because patients and their loved ones, and some of you will have had loved ones in hospitals recently or in the last year or so, when you don't know the answer to these questions, it really does feel like a red day. And they're things, I guess, they're practical things that we know we could all do. And one of my favourite phrases is putting these things in the hands of the many. So if I'm the HCA and I'm taking Nick to the bathroom, you think about that, Nick, to give you a wash and things like that, getting your slippers on, walking you to the bathroom. I could say, this is what's going to happen now, Nick. You're going to walk here, you're going to do most of the walking yourself. I may help you a little bit. Then the physio is going to see you. Then Dr. Steve Barden's going to see you. He's going to come up with a really clear plan. Then you're going to have a test, and then we'll you'll have your dinner, and we'll get you out of bed a bit later on. Just so these 4 questions I love. One of the other simple things is having a plan that's really clear. So I think it's a red day if the plan isn't really clear. And these things that are written down here aren't from me. They're from a doctor from Essex called Dr. John Day, who's got a passion for criteria-led discharge and clinical criteria for discharge. But these are things that we too often see: home when stable, home when mobile, start discharge planning, home after the weekend, medically for discharge when back to baseline, recheck bloods tomorrow. And for me, they're common, but they're not really clear. Whereas, you know, for a green day, I think a plan which is written down, you know, relatively clearly, and that the patient and or their loved one knows the plan, linking it back to the 4 questions. So this could be someone with a, you know, maybe COPD, treat with oxygen to maintain saturations of 88 to 92%, nebulized bronchodilators, oral pred for follow-up with the acute respiratory service at home team once discharged. And then importantly, the criteria for discharge: able to maintain SATs without oxygen, able to manage to the toilet, able to mobilize 10 meters. So you can see there's some physiological and some functional criteria there. And the expected date of discharge, 14th of January, 11 o'clock in the morning. TTOs to be prepared the day before discharge. So to me, that's a green day. There's lots of other reasons for green days as well. But before we open up to a conversation, it's just to say we have lots of stuff online. Some of it on Fab Stuff, some of it on our future NHS platform. You know, so if you're looking at, say, earlier discharge times, or you're looking at same-day emergency care or weekend discharges or ward and board rounds, lots of information that's readily accessible. So if you want to put your email in the chat box, we can invite you to our future NHS platform. And we also have a YouTube channel, which has lots and lots of stuff on it. It has webinars, podcasts, professionally produced videos. So my guess is if you're looking to improve something and to create lots of green days for your patients, we probably have it online somewhere. And if we don't, we probably know someone who does. So that's the slides done, Nick. So I'll hand over to you to continue the conversation.
And Terry said before we joined, and that was, she recalls that she was wearing some red and green tights once. And I remember one of my first weeks at ESIS was with Helen. Actually, I'm going to bring Helen on this one. I think we were in mid Essex, and I was attending a red and green workshop and a session. I remember the chief nurse did exactly the same. I think maybe she was wearing a half and half red and green dress and the same kind of the same tights. And I was just reflecting back that it goes back some time. In ESIS now for 4.5 years, and we've been talking about this now for some time. And it in terms of your experience, Helen, and particularly as with your deep background in nursing, where do you see this kind of thinking, and how has it progressed beyond red and green, and now in terms of how we think more about patient delays?
It's interesting, isn't it? Because, like as Pete said, this isn't a new concept, and I suppose some of the things that I noticed up and down when talking to colleagues on wards and board rounds and offering some sort of insights is that there is a tendency to think that, oh, it's red and green, we've been doing it for years, because it's not a new tool. I think what unfortunately happens in places is there's an assumption that people are saying that they're doing it, but they're actually not necessarily doing it consistently. So it's that consistent approach that's actually quite difficult to achieve, because you almost feel like you're saying the same thing over and over again. Have we checked this? Who's chasing this? It's that really making sure that the small details are really done well consistently, and everybody knows who's accountable and who's doing what, and that the session that we would normally use to say as a little huddle in the afternoon to check on the progress for all the actions for turning patients red to green, as we used to say, was actually done. So I think there's we've just done quite a lot of work up in the Midlands recently with some of the nursing and AHP leads, and although everybody's very familiar with the concept, I think probably their utilisation of it may well be different, and it may well have differed over specifically the last sort of 2 years or so, because there is this assumption that it is being done. But when you actually go back and question and just ask a couple of those other questions that Pete's raised, not everyone can answer those. So it's just some of the bits of work and some of the bits of support that we can give, I think, is really about reiterating why it matters to the patient and what the impacts for the patient are if we do this well as business as usual, and what the outcomes could be, because the outcomes are really positive, aren't they? And giving patients and nursing staff and other people looking after the patients in our care that confidence to be able to ask any one of those questions, because we should all be able to answer them. But I suspect not everybody can and does.
No, I think you're right. I think it is that assumption that things are done, isn't it? And it's how we can find ways to just check in on ourselves. I'm going to bring Steve in, Dr. Steve Barden, one of our clinical associates, who's an acute physician in Brighton. And he talked there about from the patients, very much from the patient's perspective, I think Pete was referring to sometimes this gets a little bit weaponized, performance management-y, how many green days have we got today, how many red days, how much conversion rate is there, and it all gets a little bit logged into a computer system, and nobody ever does anything with it again, and it stops to feel like anything to do with the patient at all. It's all about a kind of performance management tool. Steve, from your perspective, what do you work in quite a high turnover area, but in terms of from a clinical perspective, the delays for patients and the risks associated with that, and yourselves as an operating unit as well, what's your thoughts on how we can overcome or some of the challenges around delays and waits for patients?
Excuse me. What I'd say, fundamentally what we're talking about here is logistics, i.e. how do we get things done in the quickest time possible and get patients out of hospital as quickly as we can. We have to always understand that time heals, so that there is having nothing done in bed might be the best that we can do for you on a particular day, because you're still having the care and you're still having the treatment, but we don't actually need to do anything else. But it's about cutting down the red and it's not always about red days. I would say this is a good tool, but certainly now within acute medicine and same day emergency care environments, you're talking about red hours and green hours. And the key is how do you manage? And I would always say it's about the cohort. And when I tell the clinicians about the delays in, say, getting the TTOs ready for somebody on the ward, it's not just about that patient getting home. It's also, sadly, about the little old lady that's still on the trolley in the emergency department and needs the bed instead of someone else needing the bed. And that basically everything that we do that brings in a delay is not just a delay for a single patient. This is multiple patient problems that this is generating. So it's a good way, I'll see the red and green as a good way of identifying how to optimize the resources that you have, often hour by hour. And also the challenge, which goes beyond the 4 questions, which is an analysis of, you might have lots of things being done today in a hospital bed, but you didn't need to be in a hospital bed to have any of those things done. And therefore, you know, my specialty and my great interest and passion is same day emergency care, is actually, you know, reviewing and seeing, you know, was that echo required? You know, I wouldn't say I had an echo done today at 4 o'clock in the afternoon, and then went home after that, when you didn't need the echo in the first place as an inpatient, would be considered a green day. So you know, I think it's a very useful tool, red and green, but I would work on hours now rather than days based on the environment that I work in.
It's a fair one, to be fair, and I think we've heard that before about, you know, how the principles can be used elsewhere, and it is just about understanding where the delays exist, and if those delays exist in hours or days, whichever.
And I think it's what's in your gift. You know, there are things in all of our gifts that can actually make things easier for patients. And I always teach about, you know, I've adapted those 4 questions. The first one to me is, why am I in hospital? Because that's the key question. And it's very rarely anything to do with you about your diagnosis, or it's about, well, it helps us all in data capture to understand that, you know, pneumonia isn't a reason to be in hospital. Pneumonia with type 1 respiratory failure requiring oxygen and IV antibiotics is a reason to be in hospital. And the more we describe, you know, why someone's in hospital, the better we can be at, well, just managing patients' care. I mean, I had an interesting guy who couldn't stand up. He was only 54. Pretty sure it was going to be an inner ear infection, but he needed an MRI because he had some cardiovascular risk factors. But we can manage for that. We knew he didn't have a bleed. We started on some aspirin, and he was like, well, I'm here until my MRI is done. And I'm like, well, no, you're here because you can't stand up. You know, the MRI can be done tomorrow or the next day or any day this week as an outpatient at your local hospital. So you're not waiting for the MRI. Of course, if the MRI becomes available before you can stand up, we'd gladly do it for you here. But, you know, it's all those little things of just like, people are not in hospital because they're waiting for an investigation. They're in hospital because there is nowhere else they can be managed in their current condition. And I think...
And that often is often misinterpreted or misrepresentative in terms of the red or the green. We think that it's a green day because, well, they're waiting for something, which means that it's going to happen, and therefore it must be a green day. Well, it's not, because nothing's actually happened, and it feels to me at times we've lost that perspective on just understanding what the purpose of this, the understanding the delays, whether that's hourly or daily, understanding what are the delays, capturing those as themes and trying to do something about it. It's not just about a sticker on a wall or whatever about this is red or this is green. I want to bring Spencer in on that one a little bit as well, to be honest, about, you know, understanding a bit more around the sort of deeper root cause analysis around those themes and trends that come out of this. Is obviously originally based on principles of theory of constraints, the red and the green, understanding where your constraints are in the system and how you work through them. And I know, you know, Spencer, you've done a huge amount of work around root cause analysis. What's your thoughts in terms of your interpretation of red and green, or just understanding delays?
Thank you, Nick. I guess without going kind of too much into some of the background, I think carrying on from what everyone said, Red and Green Days, there's two parts to it for me. There's the first very operational part, that kind of real tactical understanding of what do we need to do today, and there's something about that consciousness raising within the MDT of what are we actually trying to achieve, because it gets very, very easy with 2 or 3 actions for every single patient just to get lost. And there's something about using this process to say, well, if we've got to do 10 things for these 10 patients and we can only do 5, which are the most important, and how do we prioritize those? How do we prioritize those as the team? So the second part is kind of what you were just talking about there, Nick, of the kind of the strategic part of improvement. And this is really where the theory of constraints was always aimed at. And I think this is where red to green, whether it's hours, days, or however you apply it, this is where you get most benefit. But this is often, from my experience, where organizations and trusts don't use it. So the second part of Red to Green Days is beginning to understand thematically, whether it's day by day, unit or area, or ward by ward, or over time, what are the core constraints to flow? And I think there's something here about what is constraining flow, and there's that bigger conversation to say, if a patient is going to be clinically unwell for the next 7 days and they need an MRI done before they can go, but that can be done anytime within the next 7 days. If it's not done today, then we would say in terms of learning, that's your constraint. But in terms of patient flow, that doesn't affect that patient movement out of the organization. So there's something about how do you really drill down to understanding what specifically causes problems. And I guess when you've got that, you then start to have the bigger conversations to say, if it is MRI, for example, how much wasted capacity is there, whether that's through process or inappropriate referrals or delays or things being shut down. And then you get into kind of the bigger conversations of what can we do for our biggest constraint? How can we lift that up to say, how can we absolutely maximize the capacity of this thing, whatever this thing is? And then you start kind of working backwards to say, well, if our MRI capacity is 10 per day, what can you do to change processes? What can you change around structural design within organizations to make sure that there are no lost minutes of that individual constraint? And you get to a point where there's nothing else you can do. And I think the best organizations quite often get to this point, but I suppose the next step after that is, if you know something is a constraint, how do you use the red and green hours, your red and green days, to build the business case to say, if we were to invest in a second or a third or something different, what would that do to flow? So I guess there's kind of a bigger conversation there for all organizations about how do you use it both operationally and strategically. I think the latter is normally a bit of a gap. But I think, having seen it up and down the country, loads of organizations are doing it well, but I've yet to see an organization really getting the most out of it. So I think wherever you are on your journey of implementing it, whether you're just starting out or whether you've been doing it a few years, like Helen said, there is almost certainly more you can get out of it with maybe a bit of a challenge to thinking.
Perfect, thanks. That's so well described. I'm going to come back to Pete before I maybe just ask a couple of our audience members if they have some thoughts. But in terms of that, one of our key terms that we use is keeping it simple, don't we? So keep things simple. And in terms of that continuum that Spencer was talking about, some people are starting, some people are further along. What's your thoughts in terms of if you're going to approach this kind of work, whether you call it red and green or whether you call it theory of constraints or something else, but what's your sort of top tips?
Well, first of all, I wouldn't measure the number of red days as a punitive action. So I remember when, probably when me and Terry first hooked up and we were talking about red and green days, and I remember going to a trust in London, and I'd introduced the concept, and then they said, you wouldn't guess what, Pete, we've been hammering the wards and they no longer have any red days. And it was sort of the opposite of what you want to do. So rather than beating people up, it's just saying, hey, these are the 3 major constraints for this board, this department, this directorate. And as Spencer says, the theory of constraints is, where the constraint is, that's where you focus in on. So first of all, don't measure on those, don't beat people up. But the simple question is, what are the top 2 or 3 things that cause you to have red days or red hours, and then work on those and take a quality improvement approach to it, rather than this performance management sort of approach to it. And I also think on every ward or department, and I wouldn't go sending I'm a bit pro nursing, being a nurse myself, but I wouldn't go sending nurses out to hunt for information. Is give people information so they know how they're doing. So if one of the aims is to reduce, I don't know, in a medical inpatient ward, the number of patients being in hospital for 14 days, let's have a run chart on the wall to say, are we improving or are we, getting a bit worse? If we want to get patients out a bit earlier in the day, are we getting 30% out before midday? But there's a bit of stuff about keeping it simple, a bit of social movement. So, I was a very militant staff nurse. I mean, if something didn't make sense to me and someone couldn't explain it simply enough to me, I used to think, what a load of, and I tend to say it as well. And I run ideas past my wife, who's a ward manager, who you know personally, Nick, and she just does not mess around. She just says, that is absolute beep, beep, beep. So I think it also has to make sense to the people doing the work. So managerial jargon has to be translated. People who talk about improvement in terms of using Japanese language, that has to be translated downwards. But I could speak for hours on this. I'm going to hand over to Steve.
So yeah, you just brought to light something that I remember doing when I first became a consultant, is just finding out what the delays were on a short stay ward. And everyone said to me, it's ultrasound. We can't get ultrasounds done quick enough. And then, when you dig down into it, what you find out is that lots of people are doing a 4-hour, 5-hour ward round, starting at maybe 9 o'clock in the morning. And they're going around with a single junior, or a junior who's not allowed to make a request in real time. So the delay to ultrasound was getting the form to ultrasound, not anything to do with the performance of radiology department. And I think that's just a kind of classic example in terms of what can I do that's in my control, and do I really understand what the problem is? Because if you can manage a one-stop ward round, you can get it's only reasonable to ask that ultrasounds are prioritized, that any investigation unit needs to know early in the morning who's going to get the scans. And if you're putting the scanning request at 3 o'clock in the afternoon, it's not happening till the next day, simply because of the processes, which are very reasonable based on the prioritization that's already happened. So, that's a classic easy win for medicine. But, well, I say easy, that requires a cultural change and understanding about how seniors and juniors work together on a ward round, for example.
I think it's also
just before you bring Emma and Sabir in, Nick, that is a really good example. That's the supposed constraint. Steve dug into the root cause. Then you take the quality improvement approach to it. You'd use some facts. You'd go and see. You'd use all those techniques and say, this is the situation. It's a situation of batching at the end of the ward round. Brilliant.
It's exactly that. It is exactly that. Don't always respond to the superficial. What you think is the superficial. Go be classic one for me, Steve, is TTOs. It's always about TTOs, and then we focus all our attention on TTOs. But we know that's just one part of it. We can get the TTOs done the day before, then the patient will wait another day before they actually leave the hospital because everything else hasn't been sorted out. I do want to just pivot a little bit to if Emma or Dr. Hack want to come in and respond to anything we spoke about today, or any other comments or any experience that you guys have had. Have you got any thoughts?
Hi, I'll speak. Well, I'll tell you a little bit why I joined. So we've just gone live with a big EPR, and so I've always understood the concept of red and green days, and before we had the EPR, many of the wards were just using like a whiteboard and red and green magnets. Bless them. So obviously that didn't ever pull any sort of like data as such. It was just a visual at that time. Anyway, so obviously now we've got this wonderful EPR which has got red and green days built into it. But I suppose at the moment we're kind of at the point of where you can lead a nurse to an EPR, but you can't make her doctor. So, or him, should I say? But in actual fact, I've actually probably now got more questions than ever because, but you've really got me thinking about. So that's just all right. We can get this data, but then what am I going to do with this data? But it was really interesting what you said about like taking like the quality improvement approach rather than the performance management. So thank you. It's been really interesting. But yeah, I've got a million questions.
I'm glad we've created more questions, and obviously we're always around. So just get back in touch if this is only a very short session, so it's very limited in what we can do. But if there are more questions, then we're always willing to pick those. I was going to bring Helen in really on the whiteboard versus EPR challenge, and there's always a debate around let's keep it manual or let's go electronic. What's your thoughts?
It's really interesting, isn't it, listening to that? Because actually, I was in an organisation over the summer who's got a beautiful electronic board system, and it was really something I was really quite impressed and thought was amazing. Until if people just tick it and don't do anything with it, then it doesn't matter what system you're using. It's the doing and understanding and doing something with what it's telling you that actually is going to change for your patients, isn't it? And so, I think, yes, obviously electronic stuff is great, but you've still got to be able to go out and understand it and do it. Just before Pete comes back in, listening to this, the bits that I really would advise is really helping people understand their own impact on their actions and what the small pieces that they might think is, just if I only do that, actually, is it going to have much of an impact? But if everyone doesn't do those small things, then nothing will have an impact, will it? And lastly, coming back on something Steve was saying about when you were understanding your processes, when that whole myth around what actually is an issue is so difficult to get people to understand, because there's a blanket term, and using your TTO issue as an example. But what that does is really break relationships. And actually, if you're not careful, then you've got a really distorted view and opinion of your colleagues working in other areas and other departments that then disables you from actually, having that trusting relationship and appreciating that everybody's just trying to do their job. But actually, if they're not getting referrals or TTOs until 4 o'clock, then you're not going to move your patient out. And that might not, there's a whole blame thing that sits with this. It's really hard to help people see what the impact would be if they could just, if everyone just understood it from each other's point of view. And I know it's not easy. We make it, I'm not sitting in a glass house. We're very aware of how things are currently and how in the working practices. But there's lots that could be done that could be helped.
Yeah, we're going to Pete, and I'll go back to Terry. I think Terry's got a hand up. I think the way I often frame that is that let's focus on the problem, not the people. Let's surround ourselves around the problem itself. Let's not personalize it. It's process a lot of the time. Pete, and then I'm going to go to Terry.
Yeah, mine won't take long. Mine's just the pitfalls of electronic systems. So I'm a big supporter of them, but having seen and been involved in the creation of some, these don't turn them into a Christmas tree. So everyone will say the latest thing we want to add is this, and then suddenly they want to add this, and this. Just have it as simple as possible. But they're great, but if you don't use the information, first of all, they have to be easy to use, so preferably one-touch technology. If you ask nurses to go to a separate keyboard routinely, the chances of it being accurate and them buying in is low. But then also the information that goes in has to come out as well. So, for example, Emma, in your place, you put all this red to green in and the reasons. Every ward should have, as a minimum, something called a Pareto chart, which says these are the 2 or 3 things that are causing red days, and they should be the concentration of your improvement efforts, and they should be visual on a board somewhere. But I also think on that one, if it's throwing up lots of ideas in your head, drop us a line. There's a few improvement experts, I don't include myself in that one, such as Nick and Spence from the line, who, and I'm not excluding Helen or myself either, by the way, or Steve, but who could probably offer some practical help. That's all I wanted to say on that, Nick.
Thanks, Peter. And I know Emma's from, as Roy calls, fabulous Frimley, so it's only down the road. Terry, and then Danny.
I've got a couple of questions that people have DM'd me in advance. One person who is a long-standing ward manager who just wanted to say, how do we help with this post-COVID? People were redeployed. We're getting our staff back now. Everybody's knackered. It feels like I'm starting again. And I don't know, you know, and I'm sure that's replicated around the country. You know, this kind of, really, can we just not chill a bit, please? And of course, no, we can't just chill a bit, please. But I wondered if you know, what your thoughts were, or if that was something you were seeing around the country.
Steve.
Totally recognised, but I think that goes back to the point that you know, this should not be a performance measure. This is a quality improvement tool, and
yeah,
you know, this should be used as the ward manager getting frustrated that none of her patients who have been asked for an ultrasound today ever get an ultrasound today. You know, and how we do this. The point is, this is not about hitting people with sticks. This is a way of just identifying on the wards, what are your 3 things that you would love to improve for your patients, you know, and make it personalized. And, you know, I take it with those 4 questions. I also ask my patients, how difficult is it to get back to hospital if we did this and that, you know? So you've got, it's not like a single pathway. Oh, we're going to turn all echocardiograms into outpatients and bring people back. It's like, well, if you've only got a sister who's got a car and she lives 45 miles away and she's the only person who can bring you back to hospital, you can stay to have your, you know, individualized care and your investigation. I'll push for that. But if you live down the road and you've got an active, able partner who can bring you back tomorrow or the next day, let's do it that way. You know, so it's keeping the personal, and it's keeping, you know, it for the patients. And, you know, if you're a nurse or you're a doctor and you are working on a ward and you're managing patients, it's better going home feeling that you've done something for them positive than being hit by a stick.
Yeah, absolutely. And I think that links into the second question that I've been asked, and it's about how does the ESIS team see itself kind of seamlessly working with now the real pressure point for many, social care and community trusts and community hospitals, where quite often that is the frustration and the red day. And do we see how we can make this a more seamless service pathway, where we actually at the moment have these artificial divides in the care that the patient needs, depending on whether it's third sector, community or social care?
I'm going to turn to you on that one as the head of ESIS.
Well, yeah, so Terry, that's a really good question. In the last 5 minutes, impossible to answer. What I would say is, from an acute hospital, we need to do the things that are in our gift, but there are some things which are system-wide. There are some obvious gaps out there in terms of capacity, in terms of domiciliary capacity. There are opportunities for organisations to work more closely together. What I would say is there are examples out there of people who have done really good work. I'm just going to pick on a site that I had the fortune to meet the matron from Barnsley, and they implemented the discharge to assess model as soon as the COVID pandemic took off. And it's this easy. I say easy. These are the rules to get a patient out who's rather complex. So rather than prescribing, saying, "Oh, this patient needs QDS, which is 4 times a day, double up care," the nurse from the ward phones the complex discharge team and says, "I have this old chap called Nick Holding." Probably not an old chap. This guy who's 80. He can walk 10 meters. He needs some help when he goes home. And then the band 6 is from the discharge team come to the ward within a set period of time, they do the assessment, which is trusted, and that patient will go within 24 hours. We're about to do a video with them, but that isn't commonplace. It should be as simple as that. But what they have found, because they don't prescribe, they describe what the patient needs. They haven't saturated the domiciliary care market out there. I'm not saying it's perfect or anything like that, but it's one of the best examples we've seen. For me, Terry, there's a couple of things there. There has to be a shared sense of purpose. That waiting isn't acceptable. And the other thing is people have to understand the other organisations' problems. So whether it's social care, whether it, the places, I've been doing some best practice ambulance visits, and there's a couple of things that common themes for a number of these places. And one is that the acute hospital accepts that the ambulance handover delays are their problem as well as the ambulance services delays. The other common theme is there's really good leadership and accepting that waiting isn't waiting is not a great thing. So there's no easy answer to that. It's complex, but out of complexity, just try and create simple solutions with good relationships, joint agreements, things like that. Do you want to come in on that one, Steve?
Yeah, I'd just say it goes back to the point you can only really do what's in your gift. And if I see problems with social care, there's not a lot I can do about that. And so I have to be even tighter and more efficient in those that don't need social care. So, that gives me more time to think about, getting people that don't need social care out of hospital. And so there's always a quality improvement, but, I'd say we all live in glass houses, and we can't be in a position where we think that the only problem in a hospital is patients stuck because there's no social care. It gets more difficult every year, but we can still make a little improvement.
Yeah.
Terry, I'll wrap things up in by taking it right back to something Pete said to start off with. A couple of things I just want to sort of finish on, and that's about an approach, how we do things around here. The people who do the job every day are the experts. So we've got Steve, does the job every day. He's a jobbing consultant. He knows the answers. There's no point people sitting in a committee meeting room designing the answers. Go speak to your people. They'll find the solutions. They'll find the answers. But don't make it different. One of the things that I'm eternally frustrated by is this, how we treat projects as separate to the day job. So going back to your post-pandemic comment, it's just how we do things around here. So incorporate, whether it's red and green or whether it's any other improvement approach, incorporate it into the day job. This is just how we do things around here. Whether you call it a quality improvement approach or whether you call it operational excellence or just how you do things. This has to be not a bolt on to what we already do as separate, because people won't buy into it if they feel it's separate. It's just how we do things around here. So incorporate the work, incorporate the improvements, treat it as a series of tests and experiments, try things out. Don't be afraid of failure. Sometimes things work, sometimes they don't. And that's how, for me, you incorporate things back into what we are calling now normality, because it's far from normal. So whether it's red and green or anything else, involve your people who do the work every day. If you're going to impose something on a ward or any other department, it's probably not going to work unless you really go back to Pete's wife example. She's just not going to buy into it. So there's no point going away and designing something and then just imposing it on people. Work with people, design it, and then experiment to try things out and figure it out as you go, but just make it part and parcel of what you do. I'm going to hand you back over there, guys. I don't know if anything from Danny or back to you, Terry, but I think we're just about on the 1:45 mark that we said we would try and keep it to 3/4 of an hour.
Yeah, it's so thought-provoking, and I think I'm hearing from colleagues this frustration that actually they're not doing as well as they used to, and they want to get the team together and start thinking proactively about how they can improve how they're working and their working environment and their patient experience, rather than this pressure on, clearing beds and this performance management. So I think to hear that from you is amazing, actually. I don't know if I tried to repost your postcard in the chat now, but I don't think I've successfully done it. Danny, I sent you a link, but what I'm going to do, so for our guests here now, if you would give me 5 minutes and I will put it on Twitter with the link for you, and I will put Emma, I will tag you in, and I don't know, Doctor, if you're on Twitter, if you wanted to put that, or you wanted to put your email address, and I will send you the postcard directly to you. Danny, do you have any other comments?
Yeah, for me, it's just I've popped the link into the chat for everyone. For me, it's just kind of getting thinking, really, because I left nursing last year, moved into more of an admin role, and I've gone back into nursing. I knew when I wanted to leave, so I wanted to keep up my skills. So I'm just doing agency work. So I work on multiple sites and multiple kind of wards, and just some of the things resonated from a night shift I did on Saturday, working in a short stay unit, just resonated with, actually, just all I needed to do was ask a few more questions, ready for the next morning to then have a bit more of a plan, just with patients that have come up from A&E and things. So it's just really got me thinking. So, you know, really thank you for that, because, you know, we've all got a part to play in this. And I suppose as a bank nurse, you very much treat as, well, you're only here for 5 minutes and you're gone. But actually, we can really make a difference in some of those patients' lives while we are there.
Okay, thank you very much indeed.
Brilliant.
Thank you all.
Thanks, everyone.
Thank you. Bye.
Bye. Bye-bye.